Jaundice is essentially an indicator of hyperbilirubinemia. It differs from carotenemia, which also manifests as a yellowish discoloration of the skin. But the yellowish discoloration in carotenemia is a little bit different. It's more orangish in carotenemia compared to the yellow tone in hyperbilirubinemia. We can quantify jaundice either transcutaneously or by measuring the direct serum bilirubin level. The transcutaneous bilirubin measurement is a very quick, non-invasive way of measuring the bilirubin levels. In newborns, it is widely used for initial screening of the jaundice in neonatal age group as well as for follow-up. It correlates very well with the serum bilirubin level, but in dark pigmented skin people, there may be some discrepancy. The conventional way of quantifying jaundice is by directly measure the serum bilirubin level. Most laboratories report it as the total serum bilirubin level and the direct bilirubin level, while the indirect component is calculated by measuring the difference between the two. So how we define hyperbilirubinemia? In older children and adults, the normal cutoff limit for the total bilirubin level is 1.5 milligram per deciliter, which in millimoles is 26 millimole per liter. And the conjugated fraction should always be less than 5% of the total serum bilirubin level. So we define hyperbilirubinemia when the total serum bilirubin level exceeds 1.5 milligram per deciliter. However, this landmark or cutoff is different for the neonates. It's dependent on their age and their risk factors. We will talk about it a little bit later. We usually start seeing jaundice clinically when the serum total bilirubin level has exceeded 5 milligram per deciliter. Under that, usually it doesn't become clinically evident. So how we define neonatal jaundice? Anytime a neonate, which means anytime a baby has jaundice in the first 28 days of their life, it is termed as neonatal jaundice. It is, as I mentioned, a very common entity. Almost 60% of all the babies that are born in term do develop jaundice in their neonatal age. And this number even becomes larger if they are born preterm, reaching up to 80%. However, significant jaundice only occurs in around 6% of the term babies. Also, this number is higher, up to 25% in cases of preterm. Jaundice in neonates usually starts to manifest on the face first, and then for unknown reason, it usually progresses in a cephalopolyp fashion, starting from the face and then gradually involving the lower body. And based on which part of the body is manifesting jaundice, we can roughly correlate it with the total serum bilirubin level. So if only the face of a baby looks yellow, then the estimated total serum bilirubin level will be between 4 to 8 milligram per deciliter. If the jaundice extends to the upper chest, then it roughly correlates with the total serum bilirubin level of 5 to 12 milligram per deciliter. If it progresses further to involve the trunk, lower trunk as well, then it roughly correlates to 8 to 16 milligram per deciliter of total serum bilirubin level. And if it progresses all the way to the sole of the feet, they usually consider as the total serum bilirubin level greater than 15. So before we move on further and go ahead to classify hyperbilirubinemia in units, I would just quickly go over the normal bilirubin metabolism, which I'm sure you are all must have read in some other subspecialty. This will just help us understand the different causes of neonatal jaundice. So I'm sure you all must be aware that the bilirubin actually comes from heme degradation. So whenever the RBCs are degraded and heme is released, that hemoglobin is further degraded into bilirubin, which is then changed into the unconjugated bilirubin fraction. This conversion takes place in the reticuloendothelial system, which involves the spleen, bone marrow, lymph nodes, and liver. So this unconjugated bilirubin is then released into the blood, where it gets bound to the albumin, which acts as a transporter for the unconjugated bilirubin and is taken to the liver, which is where it is taken up and is converted by the enzyme BUGT, which is bilirubin gluconal transferase, to the conjugated type of bilirubin. This conjugated bilirubin is then secreted through the biliary tract into the intestine, where most of it is converted into urobilinogen by another enzyme and is excreted into the feces. However, a little fraction, almost 5 to 10% of the total urobilinogen is degraded by the bacterial flora that is present in the intestine back into the unconjugated bilirubin and retransferred through the enterohepatic circulation back to the liver and ultimately back to the circulation. So please keep this normal bilirubin cycle in your mind so that you can understand the neonatal jaundice etiology and complications. So let's move on to classify the neonatal jaundice. They are broadly classified into the physiologic and the non-physiologic category, which is also called the pathologic jaundice. Physiologic jaundice is essentially a transient, unconjugated, or also called indirect hyperbilirubinemia in an otherwise healthy neonate that most often does not require treatment and resolves spontaneously. We never see the physiologic jaundice in the first 24 hours of life. It always appears afterwards, mostly between the second to fourth day, peaking between the third to fifth day in term infants, and a little bit later, where the peak comes a little bit later in terms of preterm birth, mostly around the 7 to 10 days. Physiologic jaundice never exceeds 15 milligram per deciliter of levels for the total bilirubin, and usually it resolves spontaneously without any treatment by the end of second week of life. Why neonates get this physiologic jaundice is because of their increased load of RBCs in the newborns, which has a shorter lifespan, and when these immature RBCs degrade and release all that heme converts into bilirubin and gives rise to a lot or a big load of bilirubin. And these neonates, coupled with this huge load of bilirubin, they are not capable of dealing with this huge load because of the defective uptake of the liver of bilirubin, coupled with defective conjugation as well as impaired excretion. So this immature conversion or dealing of the bilirubin leads to hyperbilirubinemia in neonates. So this physiologic jaundice that, as I mentioned, occurs in the first 2 weeks of life, overlaps closely with two other entities. One is breastfeeding jaundice and the other is breastfed jaundice. So what is breastfeeding jaundice? Breastfeeding jaundice begins around the same time as physiologic jaundice, which is around the second to fourth day. It is usually related to the inadequate intake of milk by the babies during the first week of life, coupled with increased enterohepatic circulation. It is usually self-limited and resolves when the baby establishes adequate feeding routine and the maternal milk supply becomes adequate. So usually it disappears by the 7 to 10 day of life. It can affect up to 13% of otherwise healthy thriving breastfeeding babies. While the other entity that correlates or overlaps closely to the physiologic jaundice is the breast milk jaundice. It's just like the physiologic jaundice, it begins in the first 2 weeks of life. The reason for getting the breast milk jaundice is due to the presence of an enzyme in the breast milk called beta gluconidase, that actually inhibits the conversion of the unconjugated bilirubin into conjugated bilirubin, and thereby increasing the load of unconjugated or indirect bilirubin in the serum, leading to breast milk jaundice. It can take a little bit longer, up to 3 months in some cases, to resolve. It is a very benign condition, but it needs to be, other organic causes needs to be ruled out to label a neonate as having breast milk jaundice. It can affect 2% of the breastfed infants in the first few weeks of life. Now moving on to the scary side or scary phase of the jaundice, that is the non-physiologic or pathologic jaundice. So when we call a neonate as having non-physiologic or pathologic jaundice, is anytime a newborn manifests jaundice in the first 24 hours of life. Remember, it is never going to be called as physiologic, it will always be pathologic. Or anytime the jaundice persists beyond 2 weeks. Anytime if a neonate has rapidly rising levels of total serum bilirubin, which we define as more than 5 milligram per deciliter in a duration of 24 hours. Anytime a neonate has a direct bilirubin component of 2 milligram, more than 2 milligram per deciliter of the total, that is considered in the pathologic category. Or if the total serum bilirubin is more than 15 milligram per deciliter. So another term that I would like to also know is the persistent or prolonged jaundice. So anytime a neonate has jaundice that is persists beyond the second week of life, it is termed as persistent jaundice. However, in the preterm infants, because they may take a little bit longer to clear up even the physiologic jaundice, the cutoff time is 3 weeks. So we will be focusing on the pathologic jaundice from now. So how we classify the pathologic jaundice? We classify into the 2 categories of hyperbilirubinemia as unconjugated or indirect and conjugated or direct. The various reasons that can lead to unconjugated or indirect hyperbilirubinemia in infants. Either it happens because of increased lysis of RBCs, which of course gives a lot of hemoglobin, which then all gets converted into the unconjugated hyperbilirubin, or any reason if the hepatic uptake of the unconjugated bilirubin is impaired, or the conjugation capacity of the liver is impaired, that may lead to unconjugated hyperbilirubinemia as well. In very rare occasion, if there is increased enterohepatic reabsorption of the unconjugated bilirubin that is generated by the degradation of the conjugated bilirubin by the bacterial flora of the intestine, we can have the indirect form of jaundice as well. So just going over all these causes briefly so that you know different disease entities that leads to indirect jaundice in humans. So the first reason or the commonest reason a newborn may have pathologic unconjugated hyperbilirubinemia is due to increased lysis of RBCs. Most of the time, this increased lysis of RBCs is due to an immune-mediated degradation of RBCs. This immune-mediated degradation of RBCs can be because of the blood group incompatibility between the mother and the newborn. Let's say if the mother, it can be either Rh incompatibility or it can be ABO incompatibility. In very small proportion of units, it can be the incompatibility among the minor blood groups. ABO incompatibility is the most common one. It happens if the mother is O, has O group with the serum containing anti-A and anti-B antibodies. These IgG antibodies get transferred to the placenta to the neonates and leads to degradation of RBCs. giving rise to all the hemoglobin degradation products, including the unconjugated or indirect bilirubin. The less common form is RH incompatibility. It happens when the mother is negative blood group and the baby is positive. It does need prior sensitization. And during the past few decades, with the introduction of the ROGAM, which is the anti-gamma globulin for the B antigen of RBCs, we are seeing it less and less in newborns. The non-immune cause of lysis of RBCs can be due to inborn enzyme defects of the RBCs. It can be either G6PD deficiency, which is a relatively common entity, or other enzyme deficiencies like pyruvate kinase deficiency. Sometimes RBC structural abnormalities also make them more prone to break down easily, leading to pathologic indirect jaundice in newborns, like hereditary spherocytosis in erythrocytosis. Occasionally, but in our setting, actually more commonly, infections can lead to degradation of RBCs and ultimately unconjugated jaundice, like sepsis or UTI. Occasionally, when the baby has sequestered blood in the form of fecal hematoma or a bruising due to a birth defect or any kind of hemorrhage, so all those collected blood, of course, the RBCs in those collected regions will be degraded ultimately, leading to unconjugated jaundice. Anytime, for any reason, a newborn has polycythemia, of course, those extra load of RBC will break down and give all the unconjugated jaundice. So that may be a reason. We do see polycythemia in infants born to diabetic mothers. The second heading for the causes of unconjugated jaundice was decreased hepatic uptake and impaired conjugation of the unconjugated bilirubin. There are two well-known syndromes that can cause that. One, the benign one, is the Gilbert syndrome, where the conjugation, the enzyme that conjugates the unconjugated bilirubin to conjugated form is lacking. Either it is completely absent or it has impaired function. The enzyme in the first step of that conversion is missing in Gilbert syndrome, and that the enzyme that is involved in the second step of the conversion is missing or impaired in function in the Crigler-Najjar syndrome. So Gilbert syndrome is actually a very benign syndrome. Most of the time, the jaundice manifests in the second decade of life, but occasionally neonates with Gilbert syndrome can have some persistent jaundice as well. Whereas Crigler-Najjar syndrome is a more aggressive form of this disease. There are two forms of Crigler-Najjar syndrome. The Crigler-Najjar syndrome 1, there is impaired function of the enzyme leading to aggressive jaundice in the newborn. Whereas in Crigler-Najjar 2, there is complete absence of the enzyme, and usually it's not very compatible with that. Hypothyroidism also leads to decreased uptake and decreased conjugation of bilirubin, leading to persistent jaundice in neonates. Again, infant of diabetic mother also has decreased hepatic uptake as well as conjugation of bilirubin, as well as polycythemia. This all leads to unconjugated bilirubinemia. And again, as we discussed earlier, breast milk jaundice can happen as well. The third reason infants or neonates can have unconjugated jaundice is because of increased enterohepatic reabsorption, which is not a very common entity that we see, but we already talked about breastfeeding jaundice. Sometimes bowel obstruction or lack of enteric feedings lead to like if an infant is on total parenteral nutrition and there is no feeding going into the intestine, that can lead to increased enterohepatic reabsorption, leading to indirect jaundice. Before I move on to the second category of pathologic jaundice, which is the direct jaundice, I would like to discuss briefly the bilirubin encephalopathy, which is a well-known complication of indirect or unconjugated hyperbilirubinemia. So anytime there is severe unconjugated hyperbilirubinemia, there is chance that the neonate can have acute or chronic bilirubin encephalopathy. So what we know already that under normal circumstances, the unconjugated bilirubin is a hydrophobic because it is always bound to the albumin while in the plasma. But when there is excess of unconjugated bilirubin in the plasma, the albumin, it exceeds the capacity of albumin to bind it, and those unbound bilirubin can cross the blood-brain barrier, resulting in brain toxicity. Affected children or neonates can present with symptoms like lethargy, hypotonia, decreased inability to feed. So those symptoms entitles as acute bilirubin encephalopathy. Initially, in the early phases, this process is reversible, and if we treat the hyperbilirubinemia promptly, the infant hopefully will grow normally. However, if hyperbilirubinemia persists for longer duration, this brain toxicity or the damage to the brain becomes irreversible, leading to cerebral palsy, sensorineural hearing loss, posturing problems, arching, as well as seizure in some cases. So this irreversible or chronic bilirubin encephalopathy is termed commonly as kernel damage. So moving on to the second category of jaundice is the conjugated hyperbilirubinemia, also known as direct jaundice. It is also referred as cholestasis, and just remember it is always pathologic. So direct hyperbilirubinemia or conjugated hyperbilirubinemia is never physiologic; it's always pathologic. And what is the cutoff to define it? Anytime the direct bilirubin level is greater than 2 mg per deciliter or greater than 20% of the total bilirubin level, when the total bilirubin level is 5 milligram per deciliter or more, that is how we define conjugated or direct jaundice. It is caused by the impaired bile formation in the liver or interrupted secretion into the intestine. It is not a very common entity, but not that uncommon as well. We can see it in 1 in every 2,500 live births in case of germ neonates. We will review the causes of direct jaundice one by one in these three categories. So, hepatocellular diseases can give rise to direct jaundice, any abnormalities in the biliary tree, or some metabolic liver diseases, as well as some systemic conditions can be related to direct or conjugated jaundice as well. So what kind of hepatocellular disease we see conjugated jaundice? The most common one that we see is the intrauterine infections. The most common ones are TORCH, including toxoplasmosis, rubella, cytomegalovirus, herpes virus, some other viruses like parvovirus and the hepatitis A to E viruses. So when the mom is infected with these viruses, we can see conjugated jaundice in the neonate. Anytime or anything that impairs the circulation or the nutrition supply to the liver leads to damage to the liver and ultimately give rise to direct jaundice in the long run. Anytime a baby is kept on parenteral nutrition for longer duration, that can impair the liver ability to conjugate, release the conjugated bilirubin due to conjugated jaundice. There are some genetic entities that can lead to conjugated jaundice. The most popular one or common one is progressive familial intrahepatic cholestasis, which has disruption of the intrahepatic biliary system, leading to impaired capability of the liver to discharge the conjugated bilirubin into the intestine, leading to jaundice. Anytime we have abnormalities, anatomical abnormalities in the biliary tree, we can see conjugated jaundice. The most common cause of these biliary tree anomalies that can lead to conjugated jaundice is biliary atresia, where if they take or malform biliary tracts, leading to impaired excretion of the conjugated bilirubin into the intestine and thereby rising jaundice. Another abnormality that we may see is choledocholecyst, a syndrome called Alagille syndrome, where there is paucity of biliary tracts within the hepatic system, and it is associated with particular faces and other anomalies that can give rise to direct jaundice. Very rarely, defect of bile acid synthesis or transport, like what we see in the progressive familiar intrahepatic cholangitis, can give conjugated jaundice. Some metabolic liver diseases and systemic conditions may be associated with the direct jaundice, like in the gestational alloimmune liver disease. It is previously known as the neonatal hemocytosis, where there is iron deposition in the liver and other organs, leading to conjugated jaundice. Neonatal hepatitis, again, is some entity that can cause direct jaundice. Alpha-1 antitrypsin deficiency can cause direct jaundice. Cystic fibrosis, again, by disrupting the biliary tract intrahepatically, can cause conjugated jaundice. Some metabolic, inborn errors of metabolism, like inborn error of carbohydrate, like galactosemia, inborn error of ammonia, like hypermethylemia, and inborn errors of amino acid, like tyrosinemia, can cause direct jaundice. Here we talked about infections like TORS, sepsis, and UTI leading to direct jaundice. Anytime, also we discussed that anytime there is acute liver injury, either due to hypoxia or impaired circulation, like shock, can give rise to direct jaundice. Few drugs can actually also lead to direct jaundice, like the most popular one is actually steroids. So what makes babies at higher risk or increased risk for jaundice? The most common one is prematurity. The second one is anytime a baby is born with a low birth weight, they of course will be at higher risk of developing any form of jaundice. Excessive weight loss in the first 2 weeks of life again leads to increased enterohepatic circulation and thereby increases the chances of a baby to develop jaundice. Anytime, as we talk about it, anytime a baby has a birth injury which leads to a collection of blood, like a big bruise or a simple hematoma, that can put them at higher risk of developing jaundice later on. Delayed meconium passage increases the enterohepatic circulation leading to jaundice. Any infection can lead to jaundice. Premature rupture of membranes by increasing the chances of infection increases their risk of developing jaundice. Maternal gestational diabetes through various mechanisms can increase risk of jaundice. Anytime a baby has a sibling with history of jaundice, especially significant jaundice requiring phototherapy, puts them at high risk as well. And of course, blood group incompatibilities. So how we approach a baby or when we have a little one with jaundice? Of course, it starts with the detailed history and physical examination. In the history, we would want to focus on their antenatal history, if they have, any maternal history of TORS infection, their gestational age, to determine if they are preterm. Of course, their birth weight will be important because you already know that low birth weight babies have higher risk of developing jaundice. A detailed history will focus on their birth history as well as family history, because we would want to know if any sibling has had history of jaundice or blood transfusion. And then, of course, we do a detailed examination to see if they are jaundice, and if they are jaundice, to look for complications. In terms of laboratory investigations, of course, whenever we see yellowish discoloration in a baby, we want to establish the total serum bilirubin level as well as the fractionated bilirubin levels. If the baby is not very sick, we can just do a transcutaneous monitoring and see if the baby is at risk of developing complicated jaundice or not. But in case of risk factors, presence of risk factor, we do always want to confirm it through a serum level. Sometimes, of course, like in cases if we are suspecting that it's not a physiologic jaundice and there can be possibility that the baby has pathologic jaundice. Let's say the baby develops jaundice in the first 24 hours of life, or it persists beyond 2 weeks of life, or any time a baby is jaundiced with other signs and symptoms. We do want to investigate more to look for any pathologic reason for developing jaundice. Of course, as you know that hemolysis or AD or incompatibility can cause jaundice, so we do want to get the baby's blood group along with a Coombs test to see if there is any evidence of discrepancy. We want to look into their peripheral smear to look for any evidence of hemolysis. It can be in the form of cystosoids or fragmented RBCs. We do want to look at their reticulocyte count. As you know, that increased reticulocyte count is also an indicator of hemolysis. We want to rule out any infection as cause of jaundice, so we want to obtain a blood culture, a urine culture, or in severely sick cases, sometimes we also want to get a CSF culture. As you know, hypothyroidism can be a cause of persistent jaundice. In those cases, we do want to get a thyroid screening as well. And again, if you are suspecting non-immune hemolysis as a cause of jaundice, you would want to assess for RBC enzymes and hemoglobin as well. Again, depending on the severity of sickness in the baby, you may want to look into other liver enzyme by doing a LFT, as well as looking into hepatic synthetic function by doing a coagulation profile and serum albumin level. Again, if the history and physical examination suggests, you may want to evaluate them for TORCH infection by doing a TORCH profile. And if the family history and there is indication on history and physical examination, you may want to work the babies up for inborn errors of metabolism. In some cases, especially in cases of conjugated bilirubin anemia, which is also called direct jaundice, you may want to get some imaging studies like ultrasound scan of the abdomen to rule out biliary effusion. If there is suspicion in the ultrasound, you may want to confirm it with a high-density scan. In some cases, you may want to get a detailed evaluation of the biliary tree by doing a endoscopic retroventricular or MRCP, which is the same thing done non-invasively with the MRI. In some cases, if we are not able to get into a cause or etiology of the jaundice in the baby, you may want to get a liver biopsy. So let's say we have a baby with jaundice, how would you manage it? So in cases of indirect jaundice or unconjugated hyperbilirubinemia, our goal is to decrease the level of the unconjugated bilirubin as rapid as we can to prevent the bilirubin toxicity or encephalopathy or kernicterus as we talked. The best way is to prevent it from happening. So early adequate feeding can actually prevent the hyperbilirubinemia, particularly the physiologic jaundice, and to getting into complicated jaundice. And in cases where we already have the hyperbilirubinemia, we may want to decrease the bilirubin levels rapidly by either doing a phototherapy or, if indicated, exchange transfusion. So what is a phototherapy? Actually, it has been around since 1960, and how it works? It works by three mechanisms. First, it does photoisomerization, which is a reversible process of the unconjugated form of bilirubin into conjugated form. It also irreversibly do isomerization of the unconjugated bilirubin into numerubin, which is a hydrophilic form of bilirubin pigment and is excreted easily in the urine and does not require conjugation by the liver to be excreted in the urine or urine. The third mechanism is photo-oxidation of the bilirubin, through which it is converted into small products which can again be easily excreted into either bile or urine without requiring conjugation by the liver. So by these three mechanisms, phototherapy converts most of the unconjugated bilirubin into some form of bilirubin product that does not require conjugation by the liver to be excreted. So it just makes the unconjugated bilirubin into more excretable, easily excretable form. Remember, phototherapy does not have any effect on conjugated bilirubin, it only targets the unconjugated form. So the decision to initiate phototherapy is actually based on the newborn's age, their risk factors, and of course their total serum bilirubin level. And we want to plot all that in a graph, which is called bilirubin nomogram, which is an hour-specific graph that helps to identify newborns that are at higher risk of developing severe bilirubin level and potential chronic damage. So here is the nomogram, and you can see three lines here. So this depicts what threshold we want to use for a particular newborn, and the threshold we want to use depends upon their risk factors. The risk factors are noted on the bottom of the graph. You just plot it according to the age and see if they are at risk or not. I would skip the technique of the phototherapy, but here is a picture of a baby receiving phototherapy. Another means if let's say the serum bilirubin level is dangerously high and we do not have time for the phototherapy to work, we want to remove the unconjugated bilirubin very rapidly. In those cases, we go for exchange transfusion, where we just replace the baby's blood with the donor's blood, and thereby removing the bilirubin pigment along with it. Of course, it carries a lot of risk, particularly hemodynamic instability, as well as electrolyte imbalances are the two most worrisome things. For the management of direct hyperbilirubinemia, it totally depends upon the cause. As you know, we cannot do anything upon the direct hyperbilirubinemia level except to treat the reason for it, and of course optimizing nutrition. So it will totally depend. Let's say if a baby has direct jaundice due to biliary atresia, they will need a surgical repair therapy. If they have it due to a metabolic disorder, they will need to have their metabolic disorder managed in order to fix the direct hyperbilirubinemia. So usually we do not have a simple management or supportive care for direct hyperbilirubinemia. We have to target the cause of it. With this, my presentation comes to end. And I will see if anyone has any questions for me. You can leave your questions in the chat box if you want. क्वेश्चन जो है
जी क्वेश्चन आंसर तो पूछते हैं आप स्टूडेंट से ना, अगर कुछ है तो तुरंत पूछ लेंगे, नहीं होगा तो
you can raise your hands, you can leave your questions in the chat box if you have any questions. If you're all good, you can thumbs up, we can communicate somehow. I don't like this one way talk, huh? Screen से बात करके चलेंगे, just ask some questions.
नहीं है तो बस
नहीं है तो नहीं चले, then we will say goodbye. Okay, best of luck. We'll see you in the next talk. दीप कहाँ है?
चेक करेंगे ना स्क्रीन पे।
जी